Hello friends, today we are going to listen a session on hypothyroidism by Dr. H.P. Chandalia. To give a short description about Dr. H.P. Chandalia, he is the Director, Diabetes Endocrine Nutrition Management Research Center. He is the Director, Endocrinology, Diabetes and Metabolism, Jaslok Hospital and Research Center, Mumbai, and Honorary Professor of Medicine and Diabetes, retired Grant Medical College, Mumbai. Dr. H.P. Chandalia, thank you.
Dear colleagues, I'll be discussing for you today a highly prevalent disorder, that is hypothyroidism, and something which concerns you most, that is the management of this particular disease. To start with, I want you to appreciate the prevalence of this disease, which is extremely common. In adult women, almost 2% of them suffer from it. The male to female ratio is almost 1 to 8 or 1 to 10. So in adult men, about 0.2%, and in neonates, 1 in 3,500. More important is to realize that the subclinical hypothyroidism is even commoner, and almost about 9.5% of the population suffers from this particular problem. The hypothyroidism can be defined very simply that it is due to insufficient secretion of thyroid hormone with resultant low levels of circulating hormone. But the subclinical hypothyroidism is defined as a condition where the TSH levels are marginally raised, and usually it is considered that above 4.1 and less than 15 microunit per ml TSH level is indicative of subclinical disease. You all are familiar with this hypothalamo-pituitary thyroid axis, and you know that hypothyroidism can originate either from the primary failure of the thyroid gland, that is the commonest form of hypothyroidism, but a pituitary disease or a suprahypophyseal lesion also can produce hypothyroidism, which is called secondary hypothyroidism. The pituitary disease can be of the nature of a tumor of the pituitary or necrosis or inflammation like hypophysitis, and most important disease that we remember causing pituitary insufficiency is the Sheehan syndrome, where of course global failure of pituitary tropic hormone occurs, and hypothyroidism is an important component of the same. To look at some of the clinical features of the disease is very important, because at times the diagnosis, even if made biochemically based upon the thyroid hormone concentration in the peripheral blood, one decides whether to treat or not. That decision is based upon some clinical findings. Of course, the commonest symptom of hypothyroidism is cold intolerance, which has to be inquired very carefully. For example, if you ask very casually any patient whether he prefers a particular temperature, everybody would say they would like to prefer a proper air conditioning temperature, which is something like 70 degrees Fahrenheit. However, if you inquire with the patient very carefully, the cold intolerance related to other people present in the room or related to the winter season during the previous year and this year, then you will get a very accurate response from the patient. And if there is a cold intolerance, there is very strongly suggestive of hypothyroidism. Remember that this symptom is almost elicited if you elicit your history carefully in more than 90% of the people. And then of course there are skin changes with which you are very familiar. Remember that the weight gain in hypothyroidism is marginal. It is roughly 3 or 5 kg weight. So that grossly obese individuals who come to you looking for the diagnosis of hypothyroidism being made on them are quite disappointed when you find the normal thyroid hormone concentration, so that the common garden moderate to severe obesity is not a result of hypothyroidism, because this disease leads to only a marginal weight gain. And part of this weight gain truly is edema and the mucinous tissue which is found all over the body. Of course, these patients, the women can have menorrhagia, excessive menstrual bleeding. Remember that most of these people will have a thyroid swelling. So that to postulate a diagnosis of hypothyroidism with a perfectly normal thyroid size is indeed hazardous. And of course, many other symptoms which you are quite familiar. Remember that it is one form of curable hypertension. So hypothyroid people may have hypertension, which is obviously curable with the thyroid replacement therapy. Now, passing on to some signs besides the thyroid enlargement, that is goiter, there can be edema and a peculiar pallor, which is partly due to anemia and partly due to hypercarotinemia, which occurs in these people. The skin is dry and coarse, and of course, there may be increased blood pressure and a slow heart rate, and most importantly, what we all elicit uh, very carefully in these people is delayed relaxation of tendon reflexes. This is best seen in the ankle, but remember that the same response of delayed relaxation at the level of ankle can occur in a variety of other diseases, which includes edema of ankles and of course old age, and hence most of the endocrinologists tend to elicit this particular feature in the biceps response. The thyroid hormones which are measured obviously is the dihydrothyronine and thyroxine, which is say T3 and T4, and of course TSH, which is always measured nowadays by a sensitive or supersensitive assay. Very important to realize that the thyroid hormones are bound, especially T4 is bound very avidly to a protein called thyroid hormone binding globulin. Almost 70% of the hormone is bound to this, and of course, 15% is bound to prealbumin, and another 15% to albumin. So you will realize that almost 99% of the hormone is bound when in circulation, and only 1% of the hormone is available for free action in the circulation. Only the free hormone is biologically active hormone. It is also important to note that the thyroid gland normally secretes, most of the secretion is of thyroxine, which is T4, and it really secretes an extremely small amount of T3 or triiodothyronine, and most of the triiodothyronine we measure in the peripheral blood really is derived from the monodeiodination of the T4. And of course, in the situations where there is a disturbances of proteins, for example, low protein or high protein, and especially low albumin, which occurs in many situations like chronic malnutrition, liver diseases, or kidney diseases, we would like to there measure the free hormone concentration, which can be done for research purposes by some very elaborate techniques like, of course, ultrafiltration and equilibrium dialysis, as is shown here. But remember that it is more, it is in clinical practice, it is more often done by a technique where the immunoassay kit is made in such a way that you see the antibody primarily only binds to the free hormone or to only the bound hormone, and therefore separation is possible. So thyroid function tests, normally we measure the T3, T4 and TSH, but in the presence of hepatic diseases or in the presence of renal failure or malnutrition, and of course in critical and chronically ill patients where again there is hypoalbuminemia. And last of all, remember that with excessive levels of estrogens or androgens, and again excessive estrogens occurring in pregnancy would alter the binding of the hormone and therefore give you false results, and it becomes imperative in these situations to measure the concentration of free hormone. Now, what is the normal level of thyrotropin has been a highly debated issue. And there have been huge studies which are shown on this slide where the the upper level of TSH has been defined. And although most hormone assays tell you, and this is what was shown in this H. Haynes study, see, that upper limit of thyroid hormone is like 4.1 microunits per ml. There are many other studies which have shown that the upper limit of normal is really as low as 2.5 or 3 microunits per ml. And therefore, remember that when we are treating a patient with hypothyroidism, we often now target a value of 2.5 or less than that in order to achieve normality. So remember that although the range of TSH is almost up to 4.1, the majority of people and the mid-range is really 2.5, and while treating people, you're going to target this particular figure. There is a lot of factors which interfere with the absorption of thyroxine, and it's important to know these factors because when we are treating people, some of them would result in the failure of your treatment, and you will find that there is persistent hypothyroidism in spite of your exhibiting doses which are ordinarily considered adequate to treat that particular person. And some of these are listed here. A most important factor which I wish to point out to you for clinical purposes is the ferrous sulfate or any iron preparation. Remember that even 10 milligrams of iron, which is contained in some vitamin preparations, also can result into poor absorption of thyroxine and therefore inadequate replacement. Of course, there are many other drugs. Very important, one other factor which should be considered is the use of H2 receptor blockers, or for that proton pump inhibitors or antacids like magnesium hydroxide or aluminum salts. They might result into poor absorption because the thyroxine tablet had to disintegrate in the stomach, and it does it better in the acidic environment. Now, about 60 to 80% of an oral dose that is administered is absorbed, so the absorption is quite good. The absorption primarily occurs over first 3 to 4 hours of ingestion and is primarily the disintegration of the tablet occurs in the abdomen and the stomach, but the absorption is in the jejunum and ileum. And remember, as I said earlier, the gastric acidity is required, and therefore some of the acid blockers that we use may also cause malabsorption or poor absorption of thyroxine preparations. There are many other drugs which interfere, and some of them again listed here. Remember the calcium salts, which are also administered very frequently to people, to women especially in the postmenopausal age, and again the iron and antacid like sucralfate and aluminum salt and magnesium salt that can cause problem. Remember, amongst the nutritional compounds, coffee, juice, cereals can also cause malabsorption of thyroxine. And of course, many other drugs, the list of which is ever expanding, can result into poor absorption of thyroxine. So for this purpose, the regular advice that these drugs should be ingested on an empty stomach in the morning is a good advice. Of course, there does not have to be any water restriction at all. And probably half an hour after the ingestion, if no meal is eaten, then you would totally avoid the interaction of thyroxine with all these drugs or with these food substances. Again, the drugs which will even cause hypothyroidism, of course, is another story. Amiodarone is a very interesting molecule. It's a delight of endocrinologists because it's almost 1/3 by weight iodine, and when exhibited by cardiologists for a variety of rhythm disturbances, amiodarone really results into either hyperthyroidism or hypothyroidism, most frequently the latter, especially in individuals who are already iodine deficient. This drug will induce acute hypothyroidism. And of course, same thing will be done by iodinated dyes and many other compounds. Remember that the soya products are also important in this regard. The thyroid hormone assay, of course, is interfered by some of these substances, which really estrogens, androgens, which really change the concentration of thyroid binding globulins. And of course, glucocorticoids also alter this and will change it. And oral contraceptives obviously contain estrogens and progesterone, which will alter the thyroid hormone binding. In a patient, when you are faced with a patient where you have replaced thyroxine in reasonably, in almost adequate doses, and you really find that there is some problem, how do you go about resolving this issue? And the best way to resolve that really is that you administer a tablet of thyroxine and then do the free T4 levels at intervals of about 1 hour for the next 3 hours. So you can do what is called a thyroid absorption test. And if you find that the absorption is quite normal, in spite of that, this person appears to continue being hypothyroid in spite of replacement, then obvious reason is non-adherence to treatment. For a drug which requires to be taken very discreetly before any meal in the morning and without probably a meal or drugs for another short period of about half an hour, the adherence is really a difficult issue because it has to be done every day at a time, and the meal and all have to be delayed for this reason. And therefore, when we want to really examine this issue, whether it is non-adherence to treatment, something very interesting can be done, and which is what again I'll be discussing a little later, and that is you give a well supervised weekly dose of thyroxine, and once you have done that and you still find that there is a problem, then of course there is malabsorption of thyroxine. But if, as it happens most often, you find that the thyroid TSH levels return to normal when you are done this well supervised weekly dosing, then you know that the problem was non-adherence. So this is a very neat way of recognizing non-adherence to treatment. Whenever we give the thyroxine by mouth in 82% of the patients, there is good absorption and you'll find the levels rise like 120 minutes after a dose. And same thing has been found in after weekly doses, that 120 minutes after that there is a rise in 82% of the cases. And of course there is a corresponding TSH reduction. So this also proves that these weekly doses will be effective. Now, when you initiate therapy in a person with hypothyroidism, what kind of rules should you follow, or what kind of algorithm you should adopt? What you really need to do is build up the replacement dose of thyroxine slowly. And of course, whatever dose you build, thereafter continue thyroxine indefinitely. And of course, once in a while, you look for the reversibility of the disease where you will be able to eliminate the dose of thyroxine or eliminate replacement therapy. Now, there are exceptions to these rules everywhere. For example, although you are going to build the thyroid dose very slowly in most of the hypothyroid people, and remember that this is true in severely hypothyroid patients, you must always build up the dose very slowly. However, the exception is a mixed edema coma, which is a grave emergency, and although the patient is perilously hypothyroid, you are yet going to exhibit a full dose or large dose of thyroxine right away to saturate the body pools with thyroxine for immediate effect. So this is with this only exception, usually the dosing is really dosing is escalated very, very slowly. And of course, to continue the drug indefinitely, but the exceptions are patients where there is a reversible form of hypothyroidism, and I will be describing those reversible forms for you as we go along. Now, what compound should you use while replacing thyroxine? And this is a complete consensus regarding this all over the world that the best is the T4 or levothyroxine sodium. It is not triiodothyronine. Many times people have considered that you should replace partly with triiodothyronine, which you know is the active form of thyroxine hormone, which originates in the body by peripheral monodeiodination and removal of one iodine atom. However, T4 is now considered a full physiological replacement for the region. The thyroid gland itself really does not directly secrete much of triiodothyronine, and most of what you measure is truly derived in the body by peripheral monodeiodination, as I told you. And of course, therefore, we normally nowadays in most patients replace them with thyroxine alone and do not consider triiodothyronine. The only situation which I might say where you may consider triiodothyronine is probably in a patient with mixed edema coma, where they are not sure of thyroxine absorption as well as peripheral conversion. There you may like to exhibit initially for a period a small dose of triiodothyronine as well. And of course, in a situation where you are treating thyroid cancer and you want to do a total body scan with radioiodine, you would like the TSH to be elevated in order to have a good uptake of the isotope, and in order to do that you omit thyroxine therapy, whereby making patients quite sick. However, you can use triiodothyronine there for a while because that will, you see, not cause the suppression of TSH, and you can still, patient will not be as sick because of your omission of thyroxine. So as I stated to you again, let me point out that the slowest escalation of dosage should occur in people who have severe deficiency. Very rarely where the patient has subclinical hypothyroidism, for example, or where you are giving thyroxine for suppression of a thyroid nodule, you can straight away go for the full suppression dose because these patients really have almost normal levels of T3, T4, and therefore suddenly exhibiting the full doses of thyroxine is not going to upset their physiology to any great extent. So, for example, subclinical hypothyroidism and suppression of a thyroid nodule, you can start with full dose right away. Now, what kind of dosage you should use? So, when you are going slow, your starting dose will be as low as 25 microgram. Some of the patients who are suffering from cardiovascular problems, it is advisable that you go as low as 12.5 microgram dose to start with, and you are going to escalate the dose roughly at 5 days interval. And anytime patient has sudden symptoms of tachycardia or discomfort in the chest or any such discomfort, you are going to probably continue the same dose for another 5 days before undertaking escalation of the dose. The final doses that are arrived in last series of patients described in the literature is usually about 1.6 to 1.8 microgram per kg in adults. Remember that this is connected with the lean body mass of the patient, and therefore it should be 1.6 to 1.8 microgram per kg of ideal weight, where the adipose tissue is not considered, because the thyroxine primarily has effect on the muscles and of course on the bone and on the adipose tissue, but to the primarily not as much in the adipose tissue, and hence the dose is connected with lean body mass. This is a series of 100 patients where we have very carefully titrated thyroxine replacement and attain the desired TSH level. There we had calculated the average replacement dose in our this small series was 1.83 plus minus zero point 0.7 microgram per kg per day. So this is a guide for you. Now in subclinical hypothyroidism, you would often find that half this dose is adequate, and therefore you see in those situations your replacement will be with much lower doses. Now, how often should you monitor hypothyroidism? Now, remember that when you keep on changing doses, a new dose will only reach equilibrium state only after a period of about 4 weeks. And therefore, earliest you can evaluate the efficacy of your dose escalation is really about a month's interval. And very often in practice, we do not do an estimation before 6 weeks. See, so roughly about 4 to 6 weeks interval, you can study the situation and of course adjust the doses. And once you have achieved good euthyroid state, you can really assess this patient once every 6 months. Always look for reversibility of the disease. Again, we'll see what are the type of hypothyroidism which may be reversible. And also you must know that hypothyroidism also is a type of immune thyroid disorder, and so also is hyperthyroidism or Graves' disease. And do not be surprised if occasionally your hypothyroid patient suddenly goes into hyperthyroidism, and you have to be on the lookout for thyrotoxicity and of course omit the replacement therapy. Remember that most of the time the clinical situation is reverse of this. That means most people who are hyperthyroid eventually evolve into hypothyroidism, but very rarely the reverse can occur, and you should be very much aware of this possibility. In case you have undertaken excessive replacement with thyroxine, what kind of symptoms a patient is likely to experience? Of course, there will be weight loss, sometimes diarrhea, and most importantly, palpitations, excessive sweating, which are more or less symptoms of hyperthyroidism. And of course, remember that in elderly people, it may induce arrhythmias. Another very important thing to realize as a side effect of excessive replacement is that with chronic therapy, it can accelerate osteoporosis, and therefore it is very important to titrate the thyroxine dose accurately and not give the excessive replacement. Now remember that we were talking about the irreversible and reversible form of hypothyroidism. And remember that if it is irreversible, you would never like to stop the treatment again. In case a patient initially has a TSH level which is as high as 50 or 100 microunit per ml, chances are that the disease is irreversible. In these people, of course, you'll adjust the dose and leave it permanently on. The reversibility can be considered in some of these situations. For example, postpartum hypothyroidism, you see, can be a reversible process. And as a matter of fact, over a year or two of follow-up, many of these individuals can become euthyroid. Viral thyroiditis suddenly produces sometimes symptoms of hyper and then transient hypothyroidism, and is usually reversible. When you suppress thyroid gland because of an adenoma, and then following suppression therapy, when we discontinue the treatment, again reversibility is there. And of course, when you discontinue antithyroid drugs, a patient who is shown hypothyroidism because of antithyroid drugs, once you stop the drugs, there will be reversibility. And remember Hashimoto's thyroiditis, you see, the patient can be euthyroid, hyperthyroid, or hypothyroid. All the possibilities exist. And of course, many times the hypothyroidism you see could be reversible. When the hypothyroidism occurs because of pituitary disease, and then the way to suspect it is because there is a pan-hypopituitarism. You will find that there is a failure of some other pituitary tropic hormones as well. And in this situation, important point to remember from therapeutic angle is that if you replace thyroxine without replacing the corticosteroids, you may precipitate an adrenal insufficiency. And therefore, it is very important for you to recognize that this is a trophoprivic or pituitary origin hypothyroidism. And causes of these are obviously some of the pituitary diseases. Again, reversibility, we have considered some of these factors where you should look for reversibility. However, how do you really test reversibility, or for that matter, how do you resolve an issue of undocumented hypothyroidism? For example, you may see a patient who is on thyroxine replacement for many years and comes to you for further advice. Now, you would like to see whether the diagnosis of hypothyroidism made was very well documented or there is no proper documentation. So, when there is no documentation and thyroxine was started without any careful consideration, how do you resolve this particular issue? And the way to do it is, of course, is that you really, what you do is you review the pre-treatment symptoms and post-treatment response. If pre-treatment symptoms were marked and post-treatment response was spectacular, it means probably the diagnosis is correct and you should not try to remove the replacement therapy. In case there is a presence of goiter and thyroid antibodies are present, then even if you think the thyroid hormone levels are normal, this patient obviously has thyroid disease, immune thyroid disorder, and hypothyroidism is part and parcel of this, and you probably will continue the replacement therapy. What do you do if you are doubtful? What you really do is you do a stepwise reduction of thyroxine dose. Instead of omitting the full doses and exposing the patient to hazard of acute hypothyroidism, one really reduces the dose in couple of steps and at the interval of 4 to 6 weeks re-evaluate patient every time clinically as well as by thyroid function tests and proceed from there. And if the patient continues to remain normal with the lowest dose of like 25 microgram, then you can omit it and then again observe for a while. In a perilous situation like mixed edema coma, the thyroxine therapy is the, of course, life-saving therapy. But remember that this is one situation where you will give large dose immediately, although the patient is severely hypothyroid, where ordinarily you start doses slowly, and there is a possibility that you use triiodothyronine judiciously. You know that these people also require corticosteroids for therapy. They may need even one ventilator support, and they have problems like hypotension, hyponatremia, and hypothermia, which will all require to be addressed. And of course, you will also see what was the precipitating illness for this mixed edema coma, and you'll attend to that. This is another situation where hypothyroidism needs to be considered very carefully. You are often referred patients in the hospital who are critically ill or who are chronically ill. And in these people, often you will find a particular pattern of thyroid hormones that is a low T3, low T4, as well as low TSH. Now, the only differential diagnosis of this probably would be either a pituitary origin hypothyroidism, because that is the only situation where the TSH is not high. In this situation, really the TSH can be normal, low, or slightly high, and therefore you see this will be a differential diagnosis. However, in chronic illness, if you find anything like this, very likely diagnosis really is sick euthyroid patient. And you see, when you do that, you see sick euthyroid patient, one clinical feature which will help you although there also can be exceptions, but remember that in a severely ill patient, you find this thyroid hormone concentrations like this. One way to sort it out really is to do the clinically the body core temperature, that is rectal temperature, and if you realize that there is subnormal or hypothermia, then it really supports the diagnosis of true hypothyroidism. But remember that some very ill patients also have somewhat low body temperature, and therefore that can confound this particular issue. One more possibility when you get thyroid hormone profile like this is that patient may still have primary hypothyroidism, but the TSH is suppressed because of some drugs, and most notorious drugs in a critical ill patient will be dopamine infusion, which is suppress the TSH and therefore resemble the profile which you see in a sick euthyroid patient. The subclinical hypothyroidism is a very, very important condition to be considered. It's very common. The upper limit there has been in various authors say 10, or some of them even say 15 or 20 should be classified as subclinical. Remember, it should be documented on couple of occasions, 2 weeks apart, if you want to be very sure that it really is present. The causes of subclinical hypothyroidism are many. Again, many of those reversible causes, the patient may go through a phase of subclinical hypothyroidism. So these are the Hashimoto's thyroiditis and of course postpartum thyroiditis and withdrawal of thyroid suppression, which are undertaken for some other region like a thyroid adenoma. And now you would like to find out whether a patient where you are diagnosed subclinical hypothyroidism by hormone assays, should that patient be treated? And there are several considerations there, and three that I list here are the most important. That is, you should carefully see if the patient has symptoms of hypothyroidism. In that case, you should replace. You should also see if a goiter is present. It's worth replacing when a goiter is present because the goiter is always indicative of a high TSH drive, and you would like to suppress the TSH in order to shrink the gland, and therefore I think is worth replacing. And whenever you have very high antibody titer, it is important to replace because you know that this is an immune thyroid disorder and it may evolve into hypothyroidism anytime and sometimes in very near future, and therefore it is worth replacing these people. Hypothyroidism with pregnancy is a very, very important situation. The fetal thyroid development starts only after about 12 weeks of gestation, and the first 12 weeks of hypothyroidism, if untreated, can result into serious problems in the fetus, including fetal loss. Therefore, thyroid hormone replacement is very, very important in pregnancy. In women who are known to be hypothyroid and on replacement therapy, it is very important to escalate the dose of thyroxine right away. Although long ago it was thought that the thyroxine demand increases only after the second trimester, but now it has been proven that very early in pregnancy there is a physiological hyperthyroid state produced by stimulation of thyroid caused by the placental chorionic gonadotropins, which have structural homology to TSH. So, a large amount of chorionic gonadotropin can produce a state of hyperthyroidism. And this relative hypothyroidism seen in the first trimester of pregnancy is physiological, and you would like to simulate the same, and hence as soon as the diagnosis of pregnancy is made in a hypothyroid person on replacement therapy, you should immediately escalate the dose. The replacement dose must of course continue uninterrupted. You see the dose should be increased by roughly about 50%, and it should not only be in third trimester but should start right from the beginning. And of course free hormone assays are mandatory. You cannot see the total T3 T4 which it changes because of the placental estrogens. And of course you see at the full term you should assess the thyroid antibodies, because these antibodies, you see, are likely to be transferred through the placenta to the fetus and may result into transient thyroid disturbances in the newborn. And of course, the thyroid function of the newborn should be assessed mostly from the cord blood, but of course you must know that the cord blood normal values are very different from the adult normal values, and you should truly properly compare those with the normal reference levels given at that stage. Postpartum thyroiditis, of course, the person can be very transiently hyperthyroid, followed by, of course, hypothyroidism. Frequently, they are antibody positive, hence, therefore, they are really Hashimoto's or autoimmune thyroiditis, and they are often reversible. Neonatal hypothyroidism is very important to detect and treat because more than a month's delay in treatment can result into permanent mental retardation. If in a child, if you find that the mother had thyroid disease and the child has goiter and poor thriving, hypothermia, constipation or somnolence, it should be thought of. Frankly, the thyroid function test we introduced as a universal screening procedure in all deliveries, and it has been done in most advanced countries, and truly we should consider that uh, in our country as well. Now, non-compliance with thyroxine therapy is a very large issue. A drug which requires to be taken every day, the patient is likely to miss it for a few days a week, or at least if we inquire carefully, few days in a month. And therefore, you see, this has been examined in the literature very carefully, and here is a study where this was examined very carefully, and 4 different thyroxine preparations, those patients who were receiving were followed for 3 months, and when they saw 82% of them, they found that there was some degree of non-compliance, that is omission of dose for few days to even probably a week or two during the whole month. And therefore, you really would like to find out where the means by which this non-compliance can be reduced almost to nil. Now, when you are faced, and how to do that also we'll consider, you see, as we go along. But very important thing again I want to discuss is that if you have a patient who appears to be inadequately replaced in spite of your exhibiting the thyroxine dose, which is like 1.8 microgram per kg of lean body mass. In that case, how should you sort out this problem? And remember that you can look at the possibility of drugs or food interacting with thyroid preparation, malabsorption syndrome. Occasionally, please look for celiac disease. So you may like to do a transglutaminase antibody there. So these are some of the methods by which you can resolve this. And in spite of that, if it is not resolved, then of course remember that you can use another method which I'll describe to you little later. So this part of the talk I can summarize by saying that when you want to replace a hypothyroid patient, thyroxine, that is T4, is the ideal. You should not truly use routinely triiodothyronine at all. Then you should initiate therapy as I described for you slowly and escalate the dose slowly. You should look for non-compliance and interference in absorption, and you should recognize that whenever the tests are not normal after giving the adequate doses of thyroxine. And you see, remember that you should monitor therapy carefully and target a value of TSH somewhere between 1.5 and 2.5 milliunits per liter. So this is the way we can summarize this. Now I want to go over to a very interesting new approach, and that is a weekly thyroxine therapy. As we saw, the non-compliance is a very large issue in this regard, and therefore weekly thyroxine therapy is very important because it is going to reduce the non-compliance considerably. Now, it has been found that the half-life of elimination of a single dose of levothyroxine is 7 days. And therefore, you see, whenever you give any large dose of levothyroxine, it will be dispersed in the body fluids and will attain a equilibrium state. And if successive doses like this are given, there is only a transient rise in the thyroxine level, but the levels remain quite constant if the same dose is used, say at large intervals, and of course interval of 1 week. So as the half-life is long, and therefore whatever you administer, it really pools, spreads into the thyroid pool and remains there with a reasonably stable level. Another very important physiological aspect one should appreciate, that the T3 is derived by monodeiodination, and this is an auto-regulated process. That means by giving large dose of thyroxine, you cannot generate lot of T3, which is the metabolically active part of the hormone. As a matter of fact, in this regard, T4 can be even considered a pro-hormone, and real hormone here can be considered, T3 can be considered the real hormone. So as this is auto-regulated and as the half-life is long, it is quite logical that exhibiting the large doses at a time also will not cause any physiological problem. Now, let me now describe for you two very good clinical trials with weekly doses, and this is one where 12 subjects were enrolled, and it was a randomized crossover design where the weekly dose and daily dose were compared in these people, and with the crossover, they came to this conclusion that the free T4 level and TSH level achieved and T3 level achieved was similar in the weekly doses as occurred in the daily doses, except for the fact that for a transient period of 2 to 4 hours after administration of a weekly dose, the, the, the rise in T3 and T4 was slightly more than what occurred with a single with the daily dose. However, it is very important, as you will see here, this transient rise, you see, is not much above the physiological range. So although this rise is above that of daily dose, it does not cross the physiological levels grossly, and therefore is not likely to produce any problem. We always study the impact of thyroid hormone in various tissues, and in this study, those have been studied also to see that this is similar to the to the daily dose therapy. And you will see here, you see the effect on the total cholesterol, which hypothyroid people have elevated LDL cholesterol, and of course here it normalized in the same way. The bone parameter was similar, and in the heart, of course, the heart rhythm and all those the findings on the 2D echo, the measurements were all similar in both the treatment groups. So we can draw this conclusion that there is no significant difference level in the level of liver enzymes and bone markers, and in the sex hormone binding globulin, so many such parameters, and therefore weekly administration of thyroxine is quite rational. Another study where similar thing was done, similar design with a crossover design again, and exactly similar conclusions were drawn. You can see the levels of free T3, free T4 achieved were similar, free T3 level achieved were similar, cardiac safety was similar. There were no arrhythmias as one would worry about because of transient rise of T3, T4 slightly higher than the routine administration. So we can draw conclusions for this part of the talk. The sevenfold higher than the usual dose significantly shows higher T4 levels right after intake, but again T3 levels did not change as much. This is very important to know. The T4 increases, but the T3 is a regulated process, so it does not increase. And therefore, I think it is possible for you to undertake this kind of therapy. Again, the safety has been carefully studied, especially the heart rate, supraventricular extrasystole has been done. So all this has been done, and this has been found to be a very safe form of therapy. It has also been shown in this study that the suppression of a goiter, and also same thing would probably apply to suppression of adenoma, also can be done by a weekly treatment, and this study shows that the weekly treatment was as effective in causing the suppression as was the daily dose. So a lot of papers have come supporting this particular scientific fact, and once weekly thyroxine treatment is considered a good strategy for non-compliance in order to introduce compliance. For example, in this case study, you will see that because the TSH did not normalize, one escalated thyroxine dose to 375 microgram once a day, which you know is the real excessive dose. However, when weekly treatment was undertaken, you see this person settled down at a much lower dose of 1 milligram in a week. You see, and therefore you see it perfectly works out to like 0.13, that is 130 microgram every day, and you can see that the non-compliance issue was resolved. And similarly, in this patient, where a large dose of 200 microgram was tried, really the TSH did not normalize, and same person normalized, you see, very easily by a weekly therapy with 750 microgram once a week. So really only about 100 microgram every day. So I think this is a very important method of tackling this non-compliance problem. So many authors have recommended use of this weekly dose in a situation where you see non-compliance. And of course, it can be supervised by a family member of the patient, may follow certain day of the week where we is not in a rush in the morning hours, for example, Sunday or a holiday, where you can take the dose properly and relate it with the meal and other medications very comfortably. So many of the international conferences, this issue has been discussed and is considered now an accepted mode of treatment. Now, in order to undertake weekly treatment, what is available are the three strengths of thyroxine tablet: 25, 50, and 100. So, if you administer 25 thyro week 25 once a week, it really is equivalent of 25 microgram daily. And of course, by combining 50 plus 25, you can achieve 75. And similarly, you see, by breaking the 25 tablet into half, you can really titrate the dose to any extent that you want, and by the same method as you titrate your daily doses. So once a weekly dose is therefore one of the very good options currently available. See, it is to be taken about 30 minutes to 1 hour before the breakfast, and of course no meal for another half an hour. You see, and if you are going to take some drugs which they interfere, you have to only separate it by about 4 hours. So we can summarize this part of the talk by saying that, you see, for hypothyroidism, where non-compliance is a very big issue, a carefully administered weekly dose is a very good option.
So thank you, Dr. Chandalia, for sharing this presentation with us and giving us a new dimension of supervised weekly dosing concept, especially for the treatment of hypothyroidism in non-compliant patients. So based on your presentation, we could find that there are few common queries which are coming, especially from some doctors. So it would be great if you actually can address to those queries as well. The first query asked is, are there lean hypothyroid patients commonly seen in India?
Yes, indeed, you can have people who are not much overweight, although they are hypothyroid, and therefore one should not always associate hypothyroidism with obesity. As a matter of fact, all grossly obese people are, most of them are not suffering from any thyroid problem at all. Obesity is a separate problem, disease itself. And when an individual develops hypothyroidism, weight gain is marginal. It's 3 kilos, 5 kilos. It is not a massive weight gain.
Okay.
And this has to be kept in mind because sometimes in the lean people, nobody thinks of hypothyroidism and a diagnosis may be missed. So it's important to know that this can occur quite, quite, quite frequently, if not most commonly, but quite frequently.
Okay. Thank you, sir. The second query is, in which all conditions do you actually recommend replacing the patient with T3?
Yeah. As we discussed, the ideal replacement really is thyroxine, T4, because this is what the thyroid gland makes. Physiologically also, it is in fact debated whether thyroid gland itself directly discharges any T3 at all. There was a time when many papers even questioned any secretion by thyroid gland of T3. But now it is more or less accepted that a very small part is secreted by thyroid gland. Rest is all by peripheral conversion. So giving thyroxine is therefore most physiological because the required amount will be converted by the peripheral tissues, for which, as we saw, the auto-regulated process of monodeiodination. Now, two situations where I alluded to, where even today use of triiodothyronine may be considered, and that is uh, patients in myxedema coma, where you want a very fast response and where you don't want to wait or give the time for that conversion, absorption of the T4 and conversion to T3, which will take some time. You may like to straightway supply the active hormone. So that is one situation. A second, which I alluded to, is patients with thyroid cancer, where periodically we stop thyroxine replacement, drive the TSH up, and then we do the radionuclear scanning to see if there are any secondaries or any tumor recurrence at the local site and secondaries anywhere else. Now, this process, when you stop TSH, patients get quite sick because you're trying to drive TSH to about 30 or 40 in order to get a good scan, but patient gets sick in the process. So there, you can stop T4, that is thyroxine, but give triiodothyronine 35 microgram 3 times a day, because this does not suppress TSS much. So also you must know that when long ago when T4 T3 combined pills were used, there was a confusion in interpreting the TSH there. And even now, if by chance somebody uses that, there is a problem because the T3 does not suppress the TSH. All the same, the metabolic effects are quite there. So you may not be able to titrate properly. So anyway, those combined pills, or what was called the crude thyroid extract, where both T4 and T3 were there, is hardly ever used now. But it is worth noting that problems that occurred when you were using those combined preparations.
So, what are the general reasons for non-compliance in thyroxine replacement therapy?
Mostly the non-compliance really is because it has to be taken certain time of the day, and there has to be no meal around it, so that sometimes in a busy schedule it is difficult to fit this daily in somebody's schedule. Although I must also allude to certain studies which show that most of the normal foods do not cause much interference in thyroxine absorption. But as we saw in several slides that I showed, the soya products can do that, and some of the foods can do that. So one really wants to avoid those somewhere near the thyroid replacement, thyroid dose. And as because of these conditionalities being applied, the patients find it difficult, and at times they will miss the dose because they are in a hurry. It's often done in the morning hours, so they're in a hurry and they will miss the dose. And as we saw, occasional missing, as we saw, who occurred in one of the studies in 82% of the people. Fortunately, it is occasional. Massive non-compliance is rare. However, it will foul the your interpretation of thyroid test will be completely flawed because you have to really find out how many doses you skip. So it really makes the titration very difficult.
So, how to recognize non-compliance in thyroid replacement therapy?
I think when you have given an adequate dose of thyroxine and yet you find that levels are not normalized or clinical response is not adequate, then one suspects that there is some problem. We call it resistant to thyroid hormone. So there are so many factors are there. I have shown you some algorithms by which we first make sure that absorption is, first of all, when the patient is taking it regularly, whether absorption is interfered with by food or drugs. See, so those are the things to see. Last of all, remember that the commonest thing after excluded these food and drug interference really is non-compliance. But how do you now prove the non-compliance? And this weekly supervised dose for about 4 to 6 weeks and then estimating the thyroid hormones is an excellent simple method because it shows that frankly, there is no other reason. If you the very small dose now or adequate dose now, the TSH is fully suppressed. It means earlier on there was non-compliance. So this is the way to determine non-compliance. This is a very good method because weekly dose can be supervised for 4 or 6 weeks. Somebody makes sure the tablet is taken, and then you see what is the result.
So even though you have answered the same question, but still there is one more question that when non-compliance is generally a fact in hypothyroid long-term therapy. So what are the ways to overcome this non-compliance? So I hope the same answer I think we gave, but
Yeah, I
would you
think.
like to add some more?
Yeah, I must also add to the previous question that one way also to see whether it is non-compliance or interference in absorption is again you give a dose of T4 and you can estimate free T4 levels at 120 minutes or 180 minutes and you find a rise there, then you know that absorption also is proper. It really is non-compliance. So this is the way you find. And of course, the best way to get around really is a weekly dose. Weekly supervised. Weekly dose can be supervised. One day a week, of course, a relative or friend or paramedic can make sure that the drug is taken.
So even though you have shared the weekly dosing, supervised weekly dosing, are there any justifications, especially related to the weekly dosing concept?
Yes, there is. Because it has been shown that we saw, it does not cause into very high levels of thyroid hormone or cause an arrhythmia in individuals or cause palpitations. See, and is well tolerated. So I think there is ample justification. And we know the long half-life, so whatever you go, it really reaches equilibrium state and maintains a pretty steady state of T4 concentration, except for 4 hours after administration. The levels are slightly high, but yet within the normal limits, especially T4 is slightly high. In fact, T3 is normal there because T3 is auto-regulated. So I think there is ample scientific justification for this kind of approach.
Okay, sir. So, are there any chances of hyperthyroidism with weekly dosing, and what precautions are needed to be taken in case?
As was shown in those two studies that I described, the hyperthyroidism does not occur in this. See, because it really is the same dose. It works out to be similar to the doses that is given daily. Some studies it comes out to be maybe 10-20% higher dose, and then it really is equal to the daily dose. And higher levels are not there as we saw. And some of those studies, even the heart was studied, there was no arrhythmia being precipitated, no extra systoles or premature ventricular contractions were seen. So it's quite safe. However, if you do have a real congestive heart failure in someone or angina, there you go to very low doses and you go over slowly. Except for those people, which makes a very small number of hypothyroid, I would not hesitate to exhibit this weekly dose in majority of hypothyroid individuals.
Okay, sir. So, how to titrate the weekly dose for newly diagnosed patients?
Yes, I think whatever titration dose you want to decide to start with, as I said, usually one starts very low. In patients where there is some history of cardiac problem, even 12.5. So you give 12.5 weekly, and in the others for 25. And then you escalate as you would have done for the daily dose in the same fashion on weekly basis. And after about 4 to 6 weeks, then you study the thyroid hormone levels and then you take it from there. You decide from there. So titration is almost similar to daily dose, except that you give a weekly dose.
So, based on your answers, now I think the management of hypothyroidism can be made little bit more easier than the current existing, therapy line. So, thank you so much, sir, for sharing your complete discussion and answering to our queries. So, thank you so much, sir.
Thank you. Thank you.